All right. Good morning, good afternoon, good evening, wherever you are, and welcome to this WHO, UNICEF, and TechNet webinar session. In this session today, we'll discuss alternative methods for the validation of maternal and neonatal tetanus elimination in armed conflict and other access constrained settings. You can listen to this session in English and French. By default, it's in English, but you can choose French. To do so, please use the toolbar at the bottom of the Zoom window. Click on the globe icon and select the language you wish to listen to this session in. So it's français for French. Let me say that in French for our francophone audience. Bonjour et bienvenue à cette session. Vous pouvez écouter cette session en français. Pour ce faire, cliquez sur l'icône en forme de globe qui est dans la toolbar de votre fenêtre Zoom et choisissez la langue dans laquelle vous voulez écouter cette session. So we'd be happy to know who's with us today. So don't hesitate to introduce yourselves in the chat. We'd be glad to know who you are, in which country you're based, maybe also the organization you work for. That would be great. So thank you in advance for that. You can also use the chat box if you have any technical issue. I'll do my best to help you in case you can't hear anything, or so let me know. I'll do my best to help you. If you have any question during the presentation, please use the Q&A box. Those who are used to the TechNet webinars know that it's the Zoom icon that says Q&A. It's available in the same toolbar that I mentioned earlier. You can ask your questions at any time. So if a speaker says something and makes you think of a question, so please go ahead and ask your question. It will be answered after the session during the Q&A session. You also received a Q&A document from me yesterday, so that you have an idea of questions that have already been answered in the past. Finally, this session is recorded. We'll share with you next week, probably, or maybe later this week, the links to the recordings as well as the slides by email. I hope you'll enjoy this session, and I'll give the floor to Nasir. Nasir, the floor is yours.
Yeah, thank you very much, Alex. Good morning, participants, and welcome to this webinar session on MNTE. I'm Nasir Yusuf. I'm the focal person for MNTE in the WHO headquarters here in Geneva. I've got with me a panel of colleagues. We've got Diana Chang, who is the team lead for the program strengthening team within WHO headquarters here. We've got Alejandro Ramirez, who is also part of that team. And then we've got Hamadu Yakubu, who is the team lead for the Accelerated Immunization Initiative in the UNICEF headquarters in New York. So that will be the panel. I'll hand you over to Diana Chang, who will take us through a bit of an introductory note and also lay out the agenda for the session. Over to you, Diana. Thank you.
Great. Thanks so much, Nasir, for the introduction, and nice to see so many diverse colleagues on the call. I think we have a very interesting session for you coming up, and it would be great to also have your participation and contributions to stimulate the conversation. So just in terms of background and why we're all together, we're at a point now where 49 of the 59 high-risk NT countries have achieved elimination as of December 2024. And so we have 10 countries left who have yet to be validated for elimination. And some of you are on the call. That's Afghanistan, Angola, CAR, Nigeria, Pakistan, PNG, Somalia, South Sudan, Sudan, and Yemen. And some of those countries are in a phased elimination status, so have eliminated in certain regions, but not for the whole country. Many of these countries have used very innovative ways to access the populations during the TTSIAs, using different NGOs and different strategies to reach the hard to reach. However, because many of the countries have limited access to these far-flung areas in the districts and the need to do house-to-house surveys, where there are issues around armed conflicts, security risks, it becomes very difficult to continue on with the traditional lot quality assessment validation survey that we have traditionally used over the past 20, 30 years. So this session is about sensitizing the participants to all the work that has been going on since 2020 to identify alternative methods to the LQA house-to-house surveys. So there is an expert group that includes WHO, UNICEF, CDC, JSI, including some former colleagues that are very well known to you, such as Francois Gass, who is on this call today, reviewed a range of literature, technical reports, used their expert knowledge to identify possible alternative methods to the standard house-to-house LQA CS method. And these alternative strategies were presented to the WHO Immunization and Vaccine Implementation Research Advisory Committee, IVRAC, to assess the pros and cons of these 4 potential methodologies in terms of how to reach places that have limited access for the surveys. And the presentation we have for you today is to sensitize you to those 4 methods that were presented to the IVRAC and focus in particularly on the 2 methodologies that were endorsed by the IVRAC for use. We don't have wide experience yet with those 2 methodologies. Mali is one of them, but it's to share what we have learned to date. So if I were to talk about how the webinar session will go, the first 45 minutes or so, you can sit back, have a cup of coffee, have a drink. It'll be very rich and informative around the 4 methodologies that were presented to IVRAC. And this will be interesting even to me. It's an IA-generated deep dive session that explains the synthesis of those methodologies, followed by a PowerPoint presentation by Nasir around the 2 options that were ultimately endorsed. Then we'll open the floor for a question and answer period. Already we have some questions that have been coming in prior to the webinar. Then we'll move over to Amadou, who is the lead on the UNICEF side for the initiative, to summarize any highlights, and then we'll close, and hopefully we'll be able to finish on time with all that. So with no further ado, I will pass on to Alex to get us going on the...
A really important topic in global health, maternal and neonatal tetanus elimination, MNTE for short.
That's right. And it's more than just a disease target. Achieving MNTE is, a sign that a country's health system is really functioning well, protecting moms and babies.
Absolutely. And what we want to dig into today is how countries actually prove they've reached this goal, especially how they do it when things on the ground are, well, difficult.
Yeah, those difficult circumstances are key because validation isn't easy.
No, definitely not. I mean, the official definition itself is tough. Less than 1 case of neonatal tetanus per 1,000 live births.
In every district?
Every single district, every single year. That's a huge ask.
It really is.
Yeah.
And getting that final WHO stamp of approval of that validation requires meeting some initial criteria first based on their regular administrative data.
Okay, so what does WHO look for in that first pass?
Well, first, obviously, that reported NT rate needs to be below the threshold, the 1 per 1,000. Yeah. Then they need evidence of strong services, either skilled birth attendants SBA covering at least 70% of births.
Okay.
Or alternatively, proof that administrative coverage with 2 or more doses of the tetanus vaccine, TTCV2 plus goose, is hitting 80% or more.
Or there's one other way too, right? Something about campaigns.
Yes, exactly. If they can show that through at least 3 big vaccination campaigns, supplementary immunization activities, or SIAs, they've reached at least 80% of women of reproductive age with 2 or more doses.
Got it. So those are the initial checks. But the real challenge and our focus today is what comes next. How do you validate this, provide rock-solid proof, especially if you're dealing with, say, security issues?
That's the core question. What methods are on the table, especially for these tricky situations, and what do the experts actually recommend?
So let's dive in. What's the main established method?
Okay, so the traditional approach, used since about 2000, is what we'll call option 1. It involves 2 main stages. Pre-validation, followed by something called an LQASCS neonatal tetanus mortality survey.
Okay, LQASCS. Bit of a mouthful. What does that actually mean?
Right, it stands for a Lot Quality Assurance Sampling Cluster Survey. It's a specific survey technique.
And it focuses on deaths.
Yes, specifically on the neonatal tetanus mortality rate. They use verbal autopsy, basically structured interviews with families about deaths, to figure out if the death rate from NT is below that magic number. 1 death per 1,000 live births. Focusing on mortality gives you better diagnostic specificity.
Okay, I see. But you mentioned pre-validation comes first. What's that about?
Yes. Pre-validation is critical. Even if a country meets those initial WHO screening criteria on paper, the pre-validation step is designed to find the districts that are still most likely to be lagging behind. It's a reality check. The team uses 16 specific indicators and local knowledge to pinpoint, usually, the 3 or 4 highest risk districts.
So they're basically saying if we can prove elimination here in the toughest spots, we can be confident about the whole country.
Precisely.
That's the logic.
And what does that pre-validation actually look like on the ground in those high-risk districts? It's quite involved. Teams go to the district health headquarters. They visit at least a couple of health facilities, review all the data they can find.
Okay.
They also do rapid assessments out in the communities, usually picking 2 large ones that depend on outreach services. And they cross-check everything reported numbers versus what they're seeing and hearing.
Trying to get a true picture.
Exactly.
So if that pre-validation looks good, if it suggests things are, probably okay, even in these tricky districts, then comes the big survey, the LQASCS.
That's the sequence. Yeah. The survey is then done in the highest risk district, or maybe a couple of them if needed for sample size.
Right.
And if that survey passes, showing the NT mortality rate is below 1 per 1,000 live births,
then the whole country gets validated.
Yes, national validation for MNTE. If the survey fails, though, it means more work is needed, corrective actions, and then you likely repeat the pre-validation later.
Okay, so option 1, it's been the main tool. What are the big pros and cons?
Well, the biggest pro is that it's well established. Most countries that are validated use this. Plus, the verbal autopsy, while sensitivity varies.
Meaning its ability to catch all the NT deaths.
Right. Sensitivity figures we've seen range like 67% in Pakistan to 83% in Bangladesh. But the specificity, its ability to correctly identify an NT death when it says it, is one that's generally high.
Like how high?
Like 89% in Bangladesh and even 99.5% in that Pakistan study. So it's good at avoiding false positives, and crucially, it directly measures the mortality rate, and the results are usually really well documented.
Sounds pretty solid. But as we said, there must be drawbacks, especially the ones leading us to discuss alternatives.
The major one, particularly in insecure places, is the sheer scale and visibility of that LQACS survey.
How so?
Think about it. Teams often need to go into 100, maybe 150 different community clusters.
Wow, that many.
Yeah, often in remote areas. And to get enough data, they need to interview families representing maybe 1,200 to 2,500 live births. That level of community presence, it could be a huge safety risk for the teams if the situation is unstable.
I can definitely see that. A lot of exposure. So given that risk, what's the expert group's advice on this, option 1?
They're pretty clear. Use it whenever you possibly can. If the situation on the ground allows for it, this is the preferred method.
Even if it means waiting.
Yes. They even suggest that if security might improve reasonably soon, it could be better to postpone validation to allow for this more thorough approach later.
Okay, so option 1 is the go-to if feasible, but if it's not, that brings us to option 2, pre-validation, but without the LQASCS survey.
Exactly. You do the whole pre-validation process just like in option 1, find the riskiest districts, investigate them thoroughly. But then if the pre-validation assessment concludes things look compatible with MNTE in those districts, you stop there. The validation decision is based solely on those pre-validation findings. No big survey.
And you mentioned Pakistan might be a place where this is considered.
It's been suggested as an example, yeah. It directly tackles that safety issue by cutting out the large-scale community work.
So the big advantage is obviously safety. Massively reduced exposure for the teams, right?
Hugely reduced. Instead of 100-plus clusters, you're talking district HQ, 2 health facilities, maybe a couple of community sites near those facilities per district, just in those 3-4 high-risk ones.
Much more manageable.
Way more manageable, especially if you can use local staff, maybe with remote support from international experts for quality control. It makes validation potentially feasible in places where option 1 is just too dangerous.
Has this actually been used?
Yes, on a limited basis. Places like the Mindanao region in the Philippines and the Somali region in Ethiopia have used approaches like this.
Okay, much safer. But the big question, without the survey actually measuring the death rate, how confident can you be?
That's the crux of it. But there is some encouraging data. They look back at 76 times when pre-validation suggested MNTE was likely achieved. And these were followed by the full survey. And in 71 out of those 76 cases, the survey actually passed.
Oh, wow.
Yeah, that gives a positive predictive value of about 93.4%. So if the pre-validation team thinks a district looks good, they're usually right.
That's pretty high confidence. What about the other way around? If pre-validation says, no, MNTE not achieved, a false negative.
Well, that's harder to measure because they generally didn't do the surveys if the pre-validation failed. So we can't really calculate sensitivity or negative predictive value for pre-validation on its own.
I see.
But the experts argue the public health harm of a false negative pre-validation is probably low, because if validation is denied, all the prevention efforts, vaccinations, clean birth practices, they just continue anyway. You don't stop trying.
Right. That makes sense. Interventions carry on. So safer, good, positive prediction.
What's the main downside then? The obvious one. You're not directly measuring the NT mortality rate. You're making an inference. You're trusting the pre-validation assessment to accurately predict what the survey would have found.
It's a judgment call, essentially.
Based on evidence, but yes, ultimately a judgment.
So what's the official recommendation on option 2 from the MNTE expert group?
They say use it, but only in places secure enough for the pre-validation work itself, but definitely too insecure for the big LQA SCS survey.
Okay, specific conditions.
Very specific.
Uh-huh.
And they stress the need for strong international coordination, remote support to keep the quality high. Interestingly, they also echo the idea of waiting if conflict might end soon, possibly allowing for option 1 later.
And they want to see it used more.
They recommend piloting it more widely, yeah, to gather more evidence on how it works in practice, balancing that risk reduction with, getting the assessment right.
Seems like a pragmatic solution for really tough spots.
Okay, moving on. Option 3 sounds quite different. Auditing vaccine campaign coverage, no survey at all. Yeah, this is for situations where even option 2, the pre-validation visits, is considered too risky, really extreme insecurity.
Wow.
In these places, sometimes the only significant way women get the tetanus vaccine is through those big SIA campaigns.
So you can't even send teams in for limited checks. You have to rely on assessing the campaigns themselves, remotely.
Pretty much.
Yeah.
You still start by identifying the 3-4 highest risk districts via desk review, but then from a safe location, you conduct an audit.
An audit of what exactly?
Of the planning, the execution, the monitoring of the last 3 SIA campaigns held in those districts. You rely heavily on info from local staff, NGOs, anyone on the ground who might know what actually happened.
And the goal of the audit.
To determine if there's enough evidence to be confident that those SIAs likely achieved at least 80% coverage with 2 or more TTCV doses among women of reproductive age in each of those high-risk districts across those 3 campaigns.
And if the audit suggests they did hit that 80% target,
then MNTE could potentially be validated based on that audit finding. Northern Mali was floated as a place where this might be the only conceivable approach.
it sounds challenging, relying on indirect information. What's the thinking behind why this might be acceptable?
The rationale is that if you use every possible information source, campaign reports, logbooks, maybe even using phones to talk to village leaders if possible, checking if vaccines arrived, if people accepted them, you might piece together a credible enough picture.
Resourceful, definitely.
And it drastically cuts the risk compared to sending teams in. Maybe you could even build auditing mechanisms into SIA planning beforehand in such areas.
What are the possible outcomes from an audit like this? It's not a simple pass-fail number, like a survey.
No, the experts see 3 potential outcomes. 1, the audit clearly shows coverage was likely below 80%. In that case, no validation.
Good.
2, the results look generally okay, but there are still big questions or data gaps. Ideally, you'd then need a coverage survey if security ever allows it. The validation would depend on that survey.
Right, which might not be possible.
Exactly. And 3, the audit provides pretty complete and consistent evidence that the 80% TTCV coverage was likely reached. In that specific case, MNTE could be validated based on the audit.
Seems like there's still a fair bit of uncertainty there. What are the pros and cons summarized?
Pros, potential for some credible information with much, much lower risk. It's also conservative. It only counts SIA doses, not routine ones.
And the cons.
That conservatism could be a con, leading to false negatives if routine services are actually contributing significantly. And the big one, if the audit is inconclusive and you need a survey to clarify, but can't do one due to insecurity, you're stuck.
So what's the expert verdict on option 3?
They are very cautious. It's not fully endorsed. They say it should only be considered if option 2 is genuinely impossible.
And with safeguards.
Absolutely. They insist on needing detailed, structured audit guidelines developed and field-tested first. And any audit results used for validation should be reviewed and signed off by an independent consultant. Plus, you have to look at any other MNTE indicators available for context.
So very much a last resort, under strict conditions. Okay, option 4. Using those big national surveys, DHS, MICS, EPI surveys, how would that work?
The idea here is quite different. You wouldn't target districts. Instead, you'd look at the results from these existing large-scale household surveys.
And validation would be based on?
It would be considered validated nationally if the survey showed either TTCV coverage at 80% or more, or skilled birth attendance at 70% or more, in every single region of the country.
Region, not district.
Right, the first subnational level, like a province or state.
That sounds appealing because these surveys happen anyway, right? What are the other upsides?
Exactly. They're often sustainable, use proper probability sampling, they're standardized. They could even potentially add serology blood tests for tetanus antibodies.
Ah, interesting.
And crucially, they already ask questions related to tetanus protection, often about protection at birth. Since they cover the whole country regionally, you wouldn't need that tricky most at-risk district identification. Plus, they might show MNTE was already achieved regionally before security deteriorated.
Lots of potential advantages there. So why isn't this the way forward, especially if other methods are too risky?
The biggest hurdle is the level of detail. These surveys are designed for regional or national estimates, not for the district level, which is fundamental to the MNTE definition.
Right, the definition is district by district.
Precisely. Also, the same insecurity preventing other options might well prevent these large surveys too. And finally, because these surveys cover so many topics, interviewer skill on the specific protection at birth questions can be variable, potentially affecting data quality for this specific purpose.
So what's the expert group's final word on using national surveys for validation?
They concluded pretty firmly that this should not be used for MNTE validation. The gap between regional data and the district level requirement is just too big.
But they see some value.
Oh yes, definitely. They see a very important role for these surveys in monitoring MNTE sustainability after it's been validated by other means. And they suggest more research is needed to better link survey findings on protection at birth with actual vaccination coverage and antibody levels.
Okay, useful for monitoring, not validation. That leaves option 5. Using the NT surveillance system itself. This feels intuitive, just count the cases reported, right?
That's the basic idea. Validation happens if the NT incidence rate reported through the country's surveillance system, assuming it meets WHO quality standards, stays below 1 per 1,000 live births in all districts.
Seems simple enough. What are the pros?
Well, if you had a really fantastic surveillance system, it could potentially be cost-effective and sustainable for the long haul. But
There's a big but.
a huge but. Right now, in most places, surveillance is only maybe reliable in some well-developed urban areas.
And the limitations overall, why isn't this common practice?
The main issue is incredibly low sensitivity. Globally, it's estimated less than 11% of actual NT cases even get reported.
Only 11%. Wow.
Yeah. Plus, there are questions about specificity. Are all reported cases truly NT? And the biggest problem, The highest risk populations usually have the weakest surveillance systems.
Makes sense.
Building a good system needs so much. Vital registration, proper case investigation for every suspected case, reporting 0 cases, site visits, record reviews. It takes a massive amount of time and resources to build that capacity.
So, not realistic for validation currently in most places. What's the expert conclusion?
They say it's not a viable option for validation right now, except maybe in a theoretical district with perfect infrastructure and investigation of every single suspected NT death, which is rare.
But they see a future role.
Yes, definitely. They strongly recommend investing in strengthening NT surveillance because it will be crucial for monitoring sustainability after elimination is validated using other methods.
Okay, so we've covered a lot of ground. 5 different options, each with trade-offs between getting accurate data, being feasible on the ground, and keeping people safe, especially in conflict zones. Can we quickly recap the main takeaways?
Sure. We started with option 1, pre-validation plus the LQASCS survey. It's the most robust data-wise, but carries the highest risk in insecure areas.
Right.
Then option 2, pre-validation only. Much lower risk, relies on the assessment predicting the survey outcome, has shown good predictive value. Option 3, auditing SIA coverage. A last resort for extreme insecurity, uses indirect info, has reliability concerns.
Okay.
Option 4, using large national surveys. Good for monitoring sustainability, but not suitable for district-level validation.
And finally,
Option 5, relying on NT surveillance. Currently not sensitive or reliable enough for validation in most settings, but vital for future monitoring.
and boiling it right down, the expert recommendations for those tough conflict-affected areas.
Primarily use option 1, if at all possible, even if it means waiting for security to improve a bit.
And if not,
If option 1 is too risky, but pre-validation option 2 is feasible, use that, but with strong oversight and quality control. They're very hesitant about option 3 SIA audit, seeing it only as an extreme last resort with strict conditions, and options 4 and 5 are basically off the table for initial validation right now.
it really paints a picture, doesn't it? The sheer difficulty, the complexity, the risks involved in just confirming that we've beaten a disease like tetanus, especially where life is already so precarious.
It really does. It
Yeah.
speaks volumes about the dedication involved in global health.
Absolutely. And maybe a final thought for you listening. When you consider these elaborate, sometimes risky methods needed just to verify progress against a disease we know how to prevent, what does that tell us? About the commitment, yes, but also about the immense challenges of reaching everyone, everywhere. And how does striving for this kind of validation, even with imperfect tools, help build stronger health systems for the long haul, protecting generations to come? Something to think about. Thanks for joining us on this deep dive.
Great. So that was my first AI-generated deep dive. And thank you, Meseret, for letting me know those were not human beings. And I hope you enjoyed that as much as I did after you got past the unusual approach. We don't normally do podcasts, but I hope you did find it engaging and fascinating the way it was delivered. I'm still a bit befuddled myself that those were not human beings. But for those who learned better visually, I'm going to invite Nasir to speak about the methods and those that were actually chosen and applied. Thanks. Over to you, Nasir.
Yeah, thank you very much, Diana. And thanks to the participants for listening to that AI-generated podcast. I think it was quite engaging. The podcast had looked at the 4 alternative methods, and then, of course, the gold standard, which is the LQASCS. Now, I'm going to present this couple of slides just to zero down on the 2 alternative methods that were endorsed by the IVAREC. Next slide, Alex. So this is the presentation outline. We look at the background, and then we look at the standard validation method. What are the challenges in conflict and access constraint settings, and then the IVAREC and those alternative methods. Then we look at what will be the next steps and the considerations to be made. What are the limitations, the implications for us going forward? And then we'll have a question and answer session. Next slide. Now, this is by way of background. Those of you who participated in the 2 theory sessions last year may have seen this slide. the World Health Assembly resolution to eliminate neonatal tetanus, which was in 1989, and then followed by the launch of the Global Initiative and the relaunch again in 1990 to include the maternal component. And then, of course, the definition of MNTE as highlighted during the podcast. And then we've got the strategy for elimination, vaccination of pregnant women during ANC, and then the targeting of women of reproductive age with rounds of TTCVSIs, and then, of course, promoting clean delivery by ensuring that women have access to skilled birth attendants during delivery and that they embark on hygienic and clean umbilical cord practices, and, of course, strengthening neonatal tetanus surveillance. Next slide. So this is the standard LQS. I've put some of these pictures here just to give you an idea of the remoteness of the areas where we conduct this assessment. This is somewhere in I think in some remote part of Pakistan. This was somewhere in Guinea. People are having to use canoe to cross the river to reach their clusters. You can see the challenging environment in which these surveys are conducted. So the LQS is the WHO recommended standard for conducting validation survey. And usually it's, of the 49 countries that have been validated, this was the method that was deployed 72 times. You'll ask why 72 times? Because some of the big countries like India that has more than a dozen states, we had to do it state by state. In Pakistan, the same thing in Nigeria. So that's why you have more surveys compared to the number of countries. And then it identifies the poorest districts for this validation. Most times it's in the area where we have challenges due to insecurity. And then we need to train teams to visit randomly selected clusters. These clusters are selected regardless of their location, because it's a random selection. You can end up in the most remote part of a country. And then a neonatal mortality audit is conducted. Usually doctors, pediatricians, public health specialists in the area where we conduct this are trained and given orientation on WHO method for conducting the neonatal mortality audit. Then the validation is based on the evidence that's obtained from the survey. As indicated in the podcast, there's limitation. For us to conduct this survey, we must have an unfettered access to communities by the survey teams. And most times, like I said, the communities are so remote. In the case of this, you can see people trying to cross to the other side in boats and all the rest. So those are the limitations. Next slide, please. Now, we have challenges in armed conflict and other access-constrained countries. Now, as Diana mentioned, of the remaining 10 countries, I've classified the countries here and the WHO regional grouping, region that they belong to. You can see we've got about 5 in the EMRO, 4 in the African region, and 1 in the West Pacific. So this, most, not the entire countries, parts of these countries like in Nigeria, in Somalia, South Sudan, Afghanistan, Central African Republic, part of these countries have limitation that severely negatively impacts and delay the implementation of MNTE, particularly the validation surveys. Next slide, please. So as Diana mentioned, we had the expert group that made a presentation, recommended 4 alternative methods to the IVAREC in February 2023. The podcast discussed all the 5 methods, including the gold standard, the LQS. But here, like I said, I'm going to concentrate on the 2 methods. So when I say option 1, it means option 1 of the 2 that were endorsed by the IVAREC. So the first one was the pre-validation without an LQS. So what's the objective of this? The objective of this is to confirm that all districts are at low risk for NT as reported by the country. And then it identifies 4 to 5 districts considered to be most at risk, despite the reports to WHO of having eliminated. The decision making is solely based on the findings from the high-risk districts. There will be no LQS to follow because of insecurity. In a normal setting, the gold standard, which is the LQS, first we conduct the pre-validation and then we generate evidence that indeed of the 4 to 5 districts visited, we have generated evidence that they have validated, but we need to verify this using the low quality cluster sampling survey method. But in this particular case, due to insecurity, we'll just stop at the pre-validation assessment. Next slide. Now, what are the advantages of this particular method? You have less community exposure. Instead of sending teams to over 150 to 200 clusters in some cases in very remote areas with possibility of exposing them to security risk, we stop at the level of the prevalence. So this community exposure is less. And it's also possible to use in setting that precludes the use of LQS because of insecurity. And it requires the possible use of local staff known to the community with remote support. What does this mean? For example, we do have insecurity, but because we still have colleagues, maybe from WHO, UNICEF partners who work at the country level, who are still able to at least assess some of these districts and operate up to the level of health facilities, but they will not be able to go to community for house-to-house visits. So we rely on this kind of this, but then we need support. So you'll have people, the internationals will go to the country, they will remain at the capital, train the staff, including WHO, UNICEF, other Ministry of Health, and deploy them to this district while they create a monitoring mechanism sitting in the capital. This was the typical example of what we did in the Southern Governorate of Yemen in November 2024. Now, the examples of use, it's been used in the Mindanao region of the Philippines and the Somali region, as I mentioned recently in the Southern Governorate of Yemen. It has very high positive predictive value. Out of the 76 LQS that were conducted, 71 representing about 94% showed that the pre-validation, the LQS that followed the pre-validation actually verified that yes, indeed, elimination has taken place. The disadvantage, it does not measure the neonatal tetanus mortality as done during the LQS. So that is the downside. And it relies on the assessment team to be able to predict that if we had the opportunity to conduct an LQS, this assessment will have resulted in a positive result through the LQSCS. Next slide. Now, the option 2. This involves the audit of the TTCV SIS, again without LQS, because insecurity will not allow us to go to the field for LQS. The context of use, this is used in districts where insecurity is so severe that neither the colleagues who are sitting in the nation's capital nor international consultant can go to the field beyond the capital. So it's used in situations where security is quite severe. Again, we had this piloted in the northern region of Mali that is conflict affected. We did this in 2023. In such areas, SIS are often the primary means of vaccinating women of reproductive age. What is the process involved? First, you conduct an initial death review and NT risk analysis to identify 4 to 5 high-risk districts that had SIS conducted, and then you try to you identify those, and then you organize a 3 to 4 day workshop in a safe location, usually in the capital. When we did the northern Mali, we sat in Bamako. We brought in the colleague from the district, the Ministry of Health, the UNICEF colleagues who are operating there, the NGOs who are operating there. We brought them to Bamako. Their counterpart from the regional and the national level joined, and then we conducted the DEX review. Now, we did an audit of the quality of the SIA rounds, using a standard structured guideline. I must confess that at this point, we do not have a WHO guideline for this, but what we did was to use a guideline that was put together by colleagues, members of the expert group. So we're hoping that in future, this guideline will be produced, and then WHO, the relevant technical committee of WHO will endorse it. So in this audit, we're looking at the planning, the budgeting, the financing. If the micro plan, did it capture all the aspects required for a successful campaign? The financing, the budgeting, did it cover all aspects? Did the funds arrive in time? Were the funds adequate? Were there shortage of funds? Were there community advocacy, communication, and social mobilization? Were the people aware? How much engagement did we have with the community? What was the coaching and vaccine management situation? Did we have the vaccines coming in the right quantity? Did they arrive in time? How was the cold chain managed? And then issues around data quality, we're looking at the AFI, and then the quality of implementation, monitoring, and evaluation. So we have this Excel spreadsheet with questions for each of these components, and then we tick them as we went along. Next. Now, still on the same option, what are the validation criteria? As you recall from the podcast, MNTE will be validated if the audit generates evidence of 80% and above coverage for the TTCV, each of the rounds. That is, if you look at the 3 rounds, count this thing covered by doses, you should be able to say that at least 80% of the women targeted received at least 2 doses of the vaccine during these 3 campaigns in the 4 to 5 districts. The decisions, if the audit supports 80% or more of TTCV2+, we say that validation has taken place. If the audit does not support, we say the validation has not taken place. And of course, if the audit conclusion do not support elimination, we request for a coverage survey. Now the question is, can coverage survey be conducted? Yes. In Mali, ahead of the workshop in Bamako, we engaged our colleagues who brought all the colleagues from the various districts to Bamako. And then some of us sitting in Geneva, others sitting in Brazzaville, and the IST, and of course UNICEF from Wekaro. We provided remote support to train this team on how to conduct this coverage survey. They went back, conducted the survey, and we had the result of the survey ahead of the workshop in Bamako. So while we were conducting the SIA quality audit, we also had information from the coverage survey. So it's possible in most instances. If a coverage survey is not required, if it's required but not possible, then the conclusion is that it remains inconclusive. We probably will request them to conduct maybe corrective SIs, and then probably see the possibility of repeating the process again. What are the potential advantages? It provides credible information for the validation decision with reduced exposed risk. We mentioned that in very severe insecurity, situation of insecurity, this is the method to take it to consider. Next slide, please. Now, we're still on option 2. What are the limitations? The result of the methods are very conservative, as you recollect during the podcast, since the TTCV doses received through SIAs are not considered. Again, this is a bit of this thing, because if we conduct the coverage survey, we tend to ask questions to women to also take into consideration other doses they received outside of the SIS. So that will make it more comprehensive. So what it's saying here is that if we just use this method alone, it's a bit conservative because we're leaving out the routine immunization doses. It may be too conservative with frequent false negative conclusions due to the exclusion of routine immunization. It is inconclusive if a required coverage survey is not possible. So if we're supposed to come and the situation is so severe that we cannot come, then we cannot make any conclusion. What is the rationale for this particular option? An audit using all available sources of information may be sufficiently accurate for MNTE validation while adequately reducing the risk of insecurity. Examples of application, like I said, we piloted it in northern region of Mali, and then the local government areas in the north central region of Nigeria. And then what are the, I mean, it also provides an opportunity to leverage technology. So where you have wireless communication means, cell phones can be used to reach out to village heads, to community contact persons and resource persons to find out, ask questions. Did rounds of campaigns actually take place in this? Did vaccinators come? All those kind of questions that can also help generate further support our claims and conclusions. Next slide. So those were the two alternative methods presented by the expert group to the IVAREC and were endorsed by the IVAREC. Now, having explained the methods, the limitations, the advantages, the rationales, and everything, what are the next steps and consideration? The methods will be deployed in more countries as pilot programs so that we can further refine it and then deploy it as necessary in parts of the remaining 10 countries. The existing validation survey guideline is being updated. That is the LQS guideline is being updated to include component on reaching, conducting surveys in security compromised settings. That we, like I mentioned, we do not as yet have a WHO guideline for conducting the SIA audit. So we hope to develop this and pass it through the relevant WHO technical committee. And then, of course, the IVAREC reiterate the importance of using the standard pre-validation followed by LQCS survey approach wherever possible. You heard that, during the podcast that, for example, if you had some abrupt insecurity, instead of going in to try any of the methods, you may as well just wait for the insecurity to abate, and then you go and conduct the gold standard, which is the LQA-CS survey. Next. Yeah. So what are the implications for us? The endorsement of these alternative methods is crucial for progressing towards eventual validation of MNTE globally, taking into consideration the challenges we have in some of these countries. They offer pragmatic approaches to assess progress and validate elimination where traditional survey methods are unsafe or impossible to implement. However, their limitations must be acknowledged, and careful consideration must be given to the specific context and the potential for less direct or potentially conservative conclusions. We need to avoid this. And then we continue to refine and develop a robust protocol and tools that will help and facilitate the implementation of these alternative methods. I think that was the end of my presentation. Next slide. I think that's the last. Yeah, thank you very much. So back to you, Diana. Diana, you are mute.
Great. Thank you. Thanks for letting me know that. So thank you very much, Nasir. That was really helpful to enhance what was discussed in the podcast. I know the podcast maybe was very informative, very rich, but maybe a little bit fast. And just to clarify, because the numbers 5 and 4 options were floating around. So just to get clear with everybody, the 5 options in the podcast, the first option was in fact the traditional method, what we've been using for a long time. And then the 4 additional methods we've been referring to are the alternative methods, which Nasir just zoned in on the 2 that seem the most likely to use, the pre-validation with no LQA cluster survey and the audit, the TTSI audit. So we have about 20 minutes to handle some questions, and we already have many questions coming in. So I don't know if it's just you alone, Nasir, who will answer them, or whether Amadou or Francois want to come in.
Yeah,
but I can start to read some of the questions.
Yes. So maybe what you can do is to read out the questions, and then between Francois, Amadou, myself, and Alejandro, we'll try to provide answers. So, Diana, we received a question ahead of you. So maybe you want to start with that.
I have that. Yeah, great. So this question is about have there been efforts taken to test the pre-validation assessment approach, or the pre-validation alone, and or the SI audit approach in countries, communities where LQA cluster surveys is possible, to better understand where these 2 approaches, the alternative ones, align with the results of a traditional validation approach, as well as whether it highlights the soft or the weak spots in those 2 alternative methods. Over to you, Nasir.
Yeah, thank you very much, Diana. I'll give it a shot, and then I'll let Amadou and Francois and Alejandro come in. So if I understand this question very well, is in the normal research and scientific world, you want to also roll this out in a country in a normal setting where you do not have insecurity, so that you can see how it compares with the standard this thing. The answer is no. We started with 59 countries, and we've been doing them annually, and then we had serious disruption by COVID between 2020 and 2022 that practically we couldn't do anything. So we didn't, while that should be the standard way to also cross-check the effectiveness of this new approach, we didn't have the luxury and the time to be able to do that. Maybe it's something we should be considering in future, but I do not know of countries that have been validated who will have the bandwidth to engage with us trying to test this in their countries. Amadou, what's your opinion?
Actually, by default, part of the presentation, the earlier presentation, has responded to this question about the fact that out of the 76 pre-validation assessments that were conducted that advised for the validation survey to go ahead, 71 of them eventually ended up having the validation as confirmed, basically. So it's by default, that question is answered. And just to say that more than 76 pre-validation assessments were conducted, but some did not advise for the validation survey to go ahead, but rather advise for the high-risk approach. Because when you see that the risk is still high, then you advise for other alternative measures in terms of then conducting TT campaigns, targeting women of reproductive age with the 3 doses of the vaccine. So the fact that out of the 76 that were advised to go ahead with the validation survey, 71 of them passed, and it's only 5 of them that failed, actually indicates that the pre-validation assessments, to some degree, is a highly intensive process that really advises for the validation only when it's almost nearly certain that it's more likely that the country will pass. So by default, I'll say we have already been doing that.
Okay, thank you very much, Amadou. Just to add again, because the question is actually the two options, not just the pre-validation, but also the SIA quality audit. Now to that, recently, this was as recent as March this year, we did depth review of the data and information from the Islamabad and the Azad, Jammu and Kashmir region, provinces of Pakistan, and felt that these provinces, based on the data we have through admin coverage, through household surveys and everything, they are likely not to have high NT high-risk districts, and therefore they were actually not targeted for TTSIs, but we ended up validating those three provinces of Pakistan through a desk review, focusing on the quality of the routine immunization and other opportunity to vaccinate women of reproductive age in those provinces. But the audit of the quality of TTSIs, we've not had the opportunity of doing that. Maybe that should be something we should be looking at. But like I said, the countries that have been validated, even getting them to conduct post-validation assessment has been such a huge distance. So the idea that we go back there and say, okay, look, we want to test a particular distance is something we need to do, but I think it's going to be a bit challenging, and maybe we might not have the resources for that. Thank you.
On that also, just to add, you already mentioned the efforts in the autonomous region of Muslim Mindanao in the Philippines.
Yes.
After attaining elimination for all the other 15 regions except the autonomous region of Muslim Mindanao, government said it was the optics were going to be very unusual to say that all the regions have attained elimination except the autonomous region of Muslim Mindanao. And we had some discussions, and eventually it was agreed that there should be some kind of a devolution of decision-making to the region to facilitate the implementation of the activities. Hitherto, several rounds of campaigns had been implemented, but only reaching single-digit coverage because of the insecurity in the area. But when the authority to implement, to be the decision makers was given to the region, in 2 years of implementation, coverage shifted to the worst performing district having more than 80% coverage by the time the last assessment was made. And this was something, a coverage survey was implemented to supplement the information that we eventually used to validate elimination. And in that area, even during some of the activities, there were bomb explosions, but yet people were able to really be very focused, because they say there is no ungoverned area in the country, because even in conflict settings, you have people that are existing, and you have healthcare workers that are working, and that have some kind of linkage to the leaders of the armed conflict. So it's basically taking advantage of such situations, and that enabled the coverage survey to be implemented despite the conflict. And as I said, the worst performing district in that area then had even more than 80% coverage, despite the fact that previous efforts led to only single-digit coverage. Over.
Okay, thank you so much, Amadou, for those additional ideas. Back to you, Diana, for the next question.
Yeah, great. Just if I could, my understanding of this question came from David Brown, whether you had, gone back to the 76 surveys and applied the alternative methods, see whether you would come up with the same results. I understood Amadou clearly saying yes for the pre-validation alone, but not for the SIAs. And I'm just querying, is that possible even, Nasir? to go back to in the way the 76, you reapplied just the pre-validation and said, did that have any predictive value? Would it even be possible to look back on the SIE data superimposed on the 76 to see if it is, possible to give any, alignment or affirmation? I understand you'd be saying, no, that's just very resource intensive, very difficult.
Yeah. So again, that question to some extent, because if you look at the method itself, you start from pre-validation. The first thing is once they have completed the campaign, the first trigger is the NT risk analysis showing that all the districts have less than one NT case per 1,000 live births. That is the first trigger. The second is the administrative coverage of the 3 rounds, indicating that women were able to get at least 2 doses during those 3 rounds. Then those are the triggers that will now allow you to say, okay, yes, based on this, we're proceeding to the LQCS. So the question is, if we were to go back to look at that, to look at these 49 countries, at the time we conducted the testing, if we were to just look at the SI quality, will they have passed? The answer is yes, because if we didn't have that coverage, we wouldn't have proceeded to the pre-validation and the LTS in the first place. So again, the question is really very, maybe it's something we need to sit down and begin to reflect on as we proceed. Yeah. So can we go to the next question for the...
Yeah, so let's do that. So if people go into the Q&A, thank you very much to Amadou, who's been answering country-specific questions from Timor-Leste, Mozambique, and I'm assuming Liberia. There's a question since we were speaking about pre-validation, let's take Rahul Shimpi's question. Could you just generally again repeat the pre-validation, the steps of a pre-validation? Could you re-emphasize that?
Yeah, so thanks, Dan. As indicated in the presentation, the first option, I'm sorry for using option 1 because it will create confusion when we go back to the conflict. When I say option 1, I'm saying option 1 of the 2 that were adopted, endorsed by the IVAREC. So option 1 is pre-validation assessment without LQS. So it means all the steps we use for the normal pre-validation assessment is what we're going to use. But the only thing is that the conclusion does not lead us to, we don't have to get to go to LQS before making the conclusion about validation. Again, what are the steps? First, the country must have completed 3 rounds of SIAs in NT high-risk districts, showing administrative coverage of 80% or more in each of those districts. And if possible, a coverage survey to triangulate this administrative coverage. So those are the things required. Now, the processes for embarking on it, I'm not sure we do have the time here to start describing all the processes, but that is the objective of this thing. So we can get back to you and share the slide with you on the steps for conducting a pre-validation assessment. Back to you, Diana. There's a question before that. There was, yeah. Diana, back to you. No, you are mute. You are on mute. Diana, you're on mute. Diana, you're on mute.
You're muted.
She's talking to herself. Diana, okay. You're on mute.
Okay. Probably. Okay, the first question from Alan Tesinku says, thank you very much for the webinar. My question is that if surveillance indicators are very poor, could the country still pass the pre-validation, or could the pre-validation be postponed until indicators are better? Probably to attempt to answer this, initially, when the initiative started, actually the focus was on surveillance to validate elimination. But surveillance for neonatal tetanus is a very dicey or challenging kind of situation. If zero case is reported, is it because it's actually zero case, or is it lack of sensitivity of the surveillance system? So then there was a shift, and then we started looking very critically at those core and surrogate indicators as mentioned by Nasir earlier. And so the place of surveillance in the whole assessment is actually not very much stressed, because, as I mentioned, we are not sure whether you are reporting cases because the cases are there, or whether you are not reporting cases because the surveillance system is very poor. So emphasis on the review is on the pre-validation assessment, and review generally is on the core indicators for neonatal tetanus and additional indicators, basically looking at immunization-related data, coverage for TT2 plus, and other related indicators, and then maternal and child health data, antenatal care coverage, clean delivery coverage, and such related information. Over to you, Nasser.
Okay, thank you very much, Amadou. And sorry, we lost Diana. She's trying to reconnect. She's having a problem with this thing. So let's continue. I don't know if we have any other question on the Q&A. We have Daudi from the IST in Harare. So his question is, for countries conducting polio SIs and also implementing LQS, is there a possibility of integrating polio and MNTE LQS? Yes, Amadou, I leave that to you. It's a tricky one.
The LKS in polio campaign is basically an in-process activity, basically meaning an activity during the implementation of the polio round itself, to assess 10 households within a given community to see if at least 8 of them have been vaccinated or not. And if 2 of them, or more than 2 of them, have not been vaccinated, then you need to take a proactive measure and then visit the community to vaccinate. So this is a very light kind of LKS, and for this, as you already had, it's looking at the whole community where the survey is going to be implemented, and then determining the sample size, and then visiting for a number of days to collect the data and then to make the analysis, while the polio LKS is basically an in-process during implementation of the polio campaign guide in terms of what corrective measures to take. So you can't mix or put the two together. Over.
Yeah, thank you very much, Ahmad. Just to add that, again, we also need to know of what are the objectives of the 2 surveys for the 2 initiatives. For polio, as Amadou said, is for you to assess the quality of the campaign you have conducted, whether certain lots have failed the survey you are conducting. Whereas for the MNTE, the final objective is to be able to identify neonatal deaths and rule out tetanus as a cause. So while the processes are the same, the final goals are quite different. So there's no way you can combine them. Thank you. So Diana, you were on mute. Yeah. Okay.
So
welcome
yeah,
back.
So I apologize for that. I don't know. I have a demon in my computer that just stopped. And so I'm on my phone. I'm on my phone right now.
Okay.
And I apologize. I don't know. Were you able to answer the question on surveillance?
Yes, Amadou did. And then we also had a question on the possibility to combine the polio LQS and the MNT LQS. And Amadou and I have just attempted to answer. I hope that that answer satisfies Daudi. Otherwise, we can continue on this separately later.
Great. And then before I disappeared, I saw that Meseret had added in a reflection on the SIA audit.
Yeah.
In the comments. I don't know, Meseret, if you wanted to voice that and come in on that.
Yeah.
Can participants speak?
I don't know whether they need to be unmuted. Alex, can you help us with,
Yes.
yeah, please unmute Meseret.
Okay, give me a second.
Okay, thanks.
Meseret Shibeshi, right?
Yes, please.
Okay. Meseret, you can speak.
Hello, can you hear me?
Yes, loud and clear.
Excellent. Thank you so much, Nasir, Diana, Amadou, and Alex. Excellent session. It will help us for those who are lagging behind. So Nasser knows which country I'm mentioning. I would not name, but this country had very good quality SIS. But then because of huge population displacement, protracted insecurity, then they have CVD-PV response, they have cholera response, so many activities. But the maternal health indicators are lagging behind or they are not present. But the SIA data is really excellent for such a situation. We are stuck because we are waiting for the maternal health indicators. Why? Population health, human resources are moved, data they cannot retrieve. So you see, we are stuck. But this would have been the best option for this country. So I'm sure Nasser knows which country it is. So,
indeed, I know. Thanks. So, yeah, so we have it. So, Meseret, thanks for raising that. And I think it's really very important because this is a country.
Yes, just a second. Why I'm raising this is we are delaying and won't it have impact because of the SIA interval? You know, yes, we have given 3 doses. But if we go 6 years, 7 years, and so on, we are risking. Plus, new risk areas would come in.
Yeah,
encourage such countries, really. Shouldn't we be, supportive enough? But this would have applied excellent head-on to this country. Thank you so much, colleagues, for giving me the opportunity.
Yeah. Thank you very much, Meseret. Back to you, Diana.
And in case Francois has some comments, he needs to be
unmuted. Francois, unmuted. We can't.
He needs to be unmuted.
Yeah. Please,
Alex.
Alex, can you kindly unmute Francois Gas?
So why don't I, while Alex is unmuting Francois, why don't we just move to the next question? Because I'm sure Francois has a number of different reflections on some of the questions so far. And I think this might have to be our last question. This is around the major lessons learned from MNTE that could apply for future maternal vaccines. For instance, RSV being perhaps one of them. So I don't know, Amadou or Nasir, if you had any reflections you wanted to add, and then we can move to Francois.
Yeah, okay, thank you very much, Dan, and thank you very much, Laura, for that, for this reflection. I think indeed the experience from the MNT campaigns and then routine vaccination of pregnant women and women of reproductive age during outreach sort of sets the standard or the basis for future maternal vaccination. And I think it's something we really need to document very well, the processes, the relevant platforms that could be used to, for future maternal Unfortunately, in most of the countries involved, I think TT is the only vaccination we're giving to mothers. We know that HPV has come in recently. I know of the influenza vaccines and all the rest. But indeed, we have a lot of literature, we have a lot of documentation on maternal vaccination with tetanus vaccine. Amadou or Francois?
Yeah. Thank you for the question, really. Looking at the recommendation for the lifetime protection from neonatal tetanus, when we give the first three doses of DTP with the T component early in life, the first year of life, with a booster recommended in the second year of life, 18 months for either Penta or DTP containing vaccine, basically. and then another dose at school entry, about 4 to 7 years of age. And the last dose was suggested for 9 to 15 years. And that was basically to tally with the HPV vaccination as well, so that it gives an opportunity to comprehensively vaccinate children, not just girls actually, because we have seen over the years that boys especially, or men, have no other opportunities for getting TT vaccine later in life. And so the recommended booster doses for TT are intended for both boys and girls. But otherwise, the timing of the last booster dose is basically to tally with the HPV vaccination so that it can be at least integrated together. And so this is at least one of the main opportunities or lessons learned in terms of school health services that have been delivering the vaccine in some countries. Some have very established mechanisms, and like Indonesia, Malaysia, etc. And it's an opportunity that should be used comprehensively to ensure that we don't just focus on giving HPV, but also ensure that girls have the opportunity to get tetanus toxoid at the same time. And once they get that, it's more likely that they will be protected later in life. And also, we know that doses given early in life build towards later protection. And so even if 1, 2, or so doses are given in pregnancy, then it's more likely than not that then they stay protected throughout. Over.
Okay. Thank you very much, Ahmad. Diana, I can see that, I don't know if we want to unmute Laura to also share her this thing, working on the other side of the maternal edition, just for a few minutes. Is that okay?
We only have 10 minutes, and I think I still, with my apologies to Laura, I think we wanted to give Francois the floor, and then Amadou needed to come in, and then I think we need to close. So,
and then sorry, we have a question in the chat, not in the
in the chat. Okay.
Yes, please, from Ndonde. Can you look at the chat?
Okay, I'm sorry, I didn't see that in the chat. So
yeah, can you read it out?
I can't actually see it. Do you mind reading it on my phone? It's a little bit
slow. So this is from Ndonde Corlin.
Okay.
My question is, during response to MNTE cases in district sanitaire, if that's what DS means, that have crossed the elimination threshold, what is the ideal interval between the second round and the third? Is it 6 months or can be done after 1 month? So this is for a country that has been validated and they detected cases, and based on WHO guidelines, if you have clusters of cases, they should respond. So the question is, what are the intervals between the doses to be given in that kind of targeted response? Amadou, do you want to come in?
Okay, so usually we recommend, as you know, 3 doses to be given. The first dose is to be given at the first contact, basically the first round of the activity. The second dose is recommended 4 weeks later, but that is a minimal interval. So if opportunities do not arise for the 4 weeks interval, it can be given as soon as possible. While the third dose is recommended to be given at least 6 months after the second dose, but that is also a minimal interval. So if it can be given later, then it's okay. And one information related to this is the longer the interval between the doses, the better the immunogenic response. But that should not be responsible for us to delay unnecessarily for longer than necessary, because there is a reason why the timings are suggested. So this is basically it.
Great.
Okay, thank you very much. Back to Diana, please.
Yeah, so just Francois, did you want to come in with any synthesized statements before we pass it over back to Amadou?
Thank you. Can you hear me?
Yeah, very well.
Okay. Okay, no, thank you for these sessions, which is very interesting and at the same time challenging in the future. I would say if I want to focus on the main topics, which was the validation through pre-validation only or through TTSIA's audit. Obviously, the pre-validation needs to be as good as possible to be trusted as a result.
Yeah.
I have to say that the pre-validation includes a rapid coverage assessment, which is like an LQA in the selected district and the selected community to assess the level of coverage conveyed by SIAs and routine as a combination. Most likely would be SIAs will be the main strategy to achieve high level of coverage. I would like to say some things that maybe not been mentioned, but there was a cross-check. Is the 80% TT protection compatible with elimination of neonatal tetanus? And the review of the past surveys has proven that 80% protection with tetanus vaccine as reported or investigated, I'm not talking about serosurvey, was compatible with MNTE elimination status, which makes the rapid coverage summary, which is like an LQA for TT protection, extremely important in the context of the pre-validation to be relevant. As an example, I would like to say that we were pleased to see a serosurvey conducted nationwide in Nigeria that revealed an extraordinary level of TT protection that never appeared in the reported data by WUENIC or whatever source. It was 88.9% of women nationwide in Nigeria were protected against tetanus when the WUENIC was reporting 60%. It raised the issue of how can we trust the reported data from tetanus when we make a review of the performance of the district. It raised the questions, and serosurvey in Nigeria, has they been able to validate the pre-validation and the validation where it was done in other districts. And it reveals that the north, which is still the part of the north, still high-risk area, was the lower seroprotection level, so it confirmed that there was a need for SIAs of quality in those areas. But I think, in summary, the pre-validation, when it becomes the tool, has to be extraordinarily precise, as Nasir mentioned, overlooked to be sure that the protocol is up to date and it is well executed and results can be trusted. Now, in terms of the audit guideline, as Nasir said, is a bit ad hoc. There's not a precise process to do it. And now it would be nice to find a way to develop, of course, the guidelines and pilot them and cross-check them and cross-check with a coverage survey, at least as a minimum, to make sure that they reflect the level of TD protection we expect. The only things I would like as a final to stress is that what happened in the past where, let's say, in countries relatively feasible to validate, pre-validate, and validate. There were countries that may have faced in some districts some health system issue, but in general, they were not that low-performing countries. But now we're entering in countries far more complicated with a far less valid routine system, which makes the challenge bigger to pre-validate or validate. Over to you.
Very helpful, very clear. Thank you so much, Francois. So we got 4 minutes left, so I will just quickly ask Amadou to wrap up or emphasize any points and maybe just speak to MNTE initiative overall.
Thank you, and thanks a lot, colleagues, really, for finding the time to be with us today. We have already had that we had 59 countries that were at high risk for maternal and neonatal tetanus, and 49 of them have already been validated for elimination, leaving us with 10 countries. And these are countries where the challenges are probably not only for MNT, but for other vaccine preventable diseases as well. And we have had some of the indicators that need to be attained that can facilitate the attainment of MNTE elimination. 70% clean delivery coverage, 80% TT2 plus coverage from routine immunization or from at least 3 rounds of campaign implemented, so that at least 80% of the women should be verified to have received at least 2 doses of the vaccine, which will then be protective. We have heard of the 5 options for the validation presented, and 2 of them, especially in the very difficult to reach, conflict-affected, access compromised areas, basically being the pre-validation assessments, which is, as Francois just mentioned, an intensive process, including field assessment in communities that are poor performing in those districts. And we've already heard of the positive predictive value of up to 93% for the pre-validation assessment compared to going ahead to be validated for the attainment of elimination as one of the preferred options for validating elimination in such settings. We also had of the second option that is accepted, which is the least accepted option, but which under trying circumstances when we can't reach communities, then we might have to resort to it, which is the assessment of TT coverage or the SIA audit, where the 3 rounds have already been conducted. And our effort now is to try to see whether it's likely that at least 80% coverage has been attained. And in some settings, we have heard that this have been actually complemented with coverage surveys, which makes the decision more easier to say. And the overall focus or challenges are really with the systems, health systems in some of these settings, which are really very challenging. And as such, if we can have some focus on strengthening the systems to be able to deliver all essential interventions, including immunization, clean delivery, cord care practices, antenatal care, etc., that will be the best option to go. But we know that these are serious challenges that we have to tackle, we have to grapple with over time, and hopefully things will improve. Our effort, basically looking forward, is to try to see what opportunities exist in the broader context of EPI reviews to see what we can integrate in terms of indicators for MNTE elimination that can serve to almost act as a post-validation assessment or so. Looking into the future, we know that we are in very trying times now with the financing situation generally. We had the privilege of having the Kiwanis, the Procter & Gamble Pampers, at some point Gavi, Gates Foundation, and that are supporting the initiative over time, and that has enabled us to conduct all the necessary activities that we have been able to. Of recent, these funding windows have really been closing, and now we have the Latter-day Saints church charities that is the main supporter of the initiative. And so we have been having consultations, and we'll keep you updated in terms of what the future holds for the standard activities that we are implementing. Understandably, when a district is at high risk, and all our efforts will be in trying to implement the campaigns to reduce the risk status of districts. But strengthening the systems, as I mentioned earlier, will be ideally the way to go. But over time, we'll keep you, as I said, updated in terms of what the future perspective holds. But we are all aware of the challenges for the moment. So hopefully things will improve in the near future, and we can continue with the activities as we see them. Thank you so much again, really, for your participation, and we keep in touch. Over to you, Diana.
Thank you so much, Amadou. So we're just a little bit after 2. Just want to thank everybody so much for sticking it out for 90 minutes in your very busy schedule. I think it was very intellectually stimulating, very rich discussion based on all your contributions and your questions. I think we all learned something about artificial intelligence. So thanking Nasir and Alex for that interesting podcast. And maybe we should have a TechNet seminar to teach us all how to use artificial intelligence to synthesize our work. And then lastly, if I could just take a moment to really honor and thank Nasir Youssef. I'd like to announce to everybody that Nasir Youssef is retiring this year. His last day with UNICEF and WHO will be on the 30th of June. And just to just take the opportunity to just express extraordinary gratitude to him for all the work he's done on MNTE for the past few years, and those who've known him for a long time, his commitment and his dedication to EPI for the past 2 to 3 decades. So thank you very much, Nasir. Thank you for everybody for sticking it out with us on this podcast, and we wish you a very happy Wednesday. Goodbye.
Thank you.
Thanks.
Bye. Thank you.
Bye-bye.
Thank you. Goodbye.